Let's take a look at some of the common EKGs that give everyone a hard time. In the first one, you can see there's narrow QRS complexes on this EKG, and each QRS complex is irregularly spaced than the other one. What is this? This is an atrial fibrillation. So, irregularly irregular rhythm with narrow QRSs most of the time and no P waves. So, you can't see any obvious P waves. You have irregular rhythm with narrow QRSs. Atrial fibrillation usually originates at the confluence of pulmonary veins. The issue with atrial fibrillation is when you have a really fast heart rate. So when you have AFib with RVR, your ventricles don't have enough time to fill, which decreases your cardiac output. Decreased cardiac output in turn causes hypotension. So how do you fix that? Best approach, you rate control the patient. So you can use AV nodal blocking agents such as beta blockers or calcium channel blockers. You could also use meds such as digoxin. If these don't work, you could go with antiarrhythmics such as amiodarone. If the patient is unstable, the best approach is synchronized cardioversion. So that was a quick 2 minutes about atrial fibrillation. Next, let's look at the next EKG. I'll give you a second to think about this one. So it's pretty obvious that there's a sawtooth pattern on the baseline with narrow QRS complexes indicating this is atrial flutter. So sawtooth pattern of P waves. This can be regular or irregular. Again, the problem becomes when you have a really fast rate of atrial flutter. At that point, you can use the same agents that you use for AFib to rate control these patients. Now, both for atrial fibrillation and flutter, you kind of need to anticoagulate the patients based on CHA2DS2-VASc score. We'll talk about CHA2DS2-VASc score in a separate video. Let's do one more. I'll give you a second to think about this one. Here, I'll zoom it in for you. Now, what you notice is obviously there is no clear P waves before any QRS complexes. So, no obvious P waves. You have a narrow QRS complex. So, narrow QRSs. And you can kind of see that this rhythm looks regular. Can you tell how fast this rhythm is going? Just by the look of an eye, you can kind of see the difference between two R waves is almost 1.5 large squares. So the rate would be somewhere between 300 and 150 per minute. Let's say the rate is 200 per minute. Now this isn't sinus tachycardia because sinus tachycardia would have a P wave before every QRS complex. This kind of arrhythmia is called PSVT or AV nodal reentrant tachycardia, AVNRT or AVRT. This kind of arrhythmia originates mostly around the tricuspid valve, around the AV node and goes in both directions. The way you treat this is you use adenosine. Do you guys know the dosing for adenosine? Okay, so we use 6 mg. If that doesn't work, we use 12 mg. That doesn't work, we use 12 mg. The way we give adenosine is using a 3-way IV cannula. We push adenosine and then we push saline really fast because of a very short half-life of adenosine. If you like this one, I'll keep making more such videos.